No, we can't see it in full screen mode.
Or is it possible to share from your end and someone has to be upgrade, means one after one? Can you do that?
Yeah, like if you can give me access to share, then I'll do that.
Then that would be easier. Yeah. Let me try that. Or just hold on. In full screen mode, you are not seeing anything, right?
No, we can see, but not in full screen.
So I'm trying to do another thing. Let me share my entire screen. Let me try with that way also.
Okay, okay, fine.
So if possible, let me see.
Yeah.
Can you see now?
Yes, yes, yes.
It's coming, right?
Yes, yes.
Okay. Okay, let me know when to start. I don't know who are there in the students, how many students. It is very difficult to take class in this way, at least in the first class at the beginning. So how many students are there in the classroom and in which background? Can you just briefly tell me?
Dr. Sandeep, can I advise that from both sides cameras be turned on, Dr. Sandeep, from your side as well as now?
So I can switch on
PA
my
to be turned
camera.
on.
Let me try. But from the other side, yes. This is the entire classroom is faded actually. I can see anyone. It's fully.
I think it's so the settings and the screen have to be made to be focused and not, I think the background settings have to be changed maybe.
Sir, can you share the slides?
Yes, sure. Can you see it now?
Yes. Yes, yes.
Okay. Okay. So good afternoon, everyone. Can I start?
His voice is very faint.
Yes.
So actually, the problem is I can't hear what Dr. Kalani has just described you, all of you. So of course, that would be basic epidemiology. So I'll be taking only one part of that full courses. That is mathematical epidemiology. How we will be we can develop.
At second stage, we should have exact schedule for next 2 months. Then after 2 months, we can do it in next 15, 20 days, a month. Like so, each lecture, how are we going? Like who is going to do that? And
I'm sorry I couldn't attend your class. It's okay. But I couldn't join on that team from my this thing. So I'm trying to hear what Professor Mandal is trying to say.
Both of you are talking.
Yeah, I finished mine, but I believe the students were quite okay.
How many were there?
Not 100. 60 of them were there.
They will come.
They'll come.
If you tell them we'll give AA to everyone,
I told that.
then they'll come.
I said that if you try very hard, then you might get a B plus, but not below that. But I'm not able to hear what
It's
Professor.
like in medicine, you have to try very hard to fail MBBS.
Hello?
So at this stage, how many students are there in the classroom?
Yeah. See, it does not. It is more about the examiner not wanting to take your exam again.
Okay.
And it is one of those, we had in our college that there are 3 medical colleges in Orissa. So if my internal went and failed 30 staff students of theirs,
So
then
they
he
will
will come and take 40 students of ours. So it all used to work on those, not that how much you know and how much you don't know. The medicine was never that.
Could we meet?
How was your class?
Good, good. I
Okay,
have
Bhave.
213 people registered.
Let me know when I can start. Hello. Can I start taking my class?
Hello, Sandeep sir. We can start.
Okay, okay. Just I was asking how many students are there in the classroom. Can anyone please tell me?
Around 30-40 are here. 30-40 students are present in classroom.
Okay. And okay. And which background? Can you please ask them or someone? Dr. Kollani is there? Okay, anyway.
Good afternoon, sir. We have a mix of students from BTech as well as PhD students. So BTech students are from either CSE background. There are some from metallurgy also. And we are PhD students from KCDH and also people who've taken this as a minor.
Okay, okay, okay. Okay, that's good. That helps me actually for understanding the classroom. Okay. So after Kollani's talk, actually, what I am going to discuss today, just to give you an overview about what I am going to teach. Actually, means this is on mathematical epidemiology. Is a part of basic epidemiology. Is not the complete course. Mostly, Dr. Kollani will be teaching you all the lectures what she has described already. So I'll be only describing you only some part, only 6 or 7 classes might be I will be taking to describe mathematical epidemiology, how we develop models, mathematical models, and how to use it as a tool for public health policy making or any other purposes or strategy development.
Dr. Sandeep, sorry, I was in a institute heads meeting. So I just want to briefly introduce you right at the outset.
Okay.
Permit me to do that, please.
Yeah,
So,
please, please.
so Dr. Sandeep Mandal is a mathematical modeler and currently consulting WHO Southeast Regional Office, ICMR Delhi. I mean, he has been there. He's also been John Snow India Private Limited and Evener Health USA. He's trained in physics. He completed his doctoral work in theoretical ecology in 2009 from Vishwa Bharati University, India. And his postdoctoral research, he worked in mathematical epidemiology of human malaria, the CSIR Center for Cellular and Molecular Biology, Hyderabad. He has several years of research experience at Indian Institute of Science Education, Research Mohali, Tokyo University of Marine Science and Technology, Japan, in very interdisciplinary areas. And he joined PHFI Delhi in 2014. Later on, he was at ICMR Delhi in 2019. His main contribution is in the area of tuberculosis policy development, for 11 countries in WHO Southeast Asia region. He also provided technical support for some countries such as Nepal, India, of course, and Bangladesh as well to help frame their national strategic plans on tuberculosis. He also approached by the Geneva-based Stop TB Partnership to provide modeling analysis for their most recent global plan to end TB. So he is a part of the national task force at ICMR, and especially during the pandemic period, he supported the ICMR for planning various important policy decisions in controlling COVID-19 in India. And I'm sure some of that will actually come to the fore during his presentation of mathematical epidemiology. Thank you, Dr. Sandeep. And I apologize to the class. I have to be in a heads meeting, hence I'm away. Thank you.
No, that's okay. Thank you. Thank you, Dr. Ganesh, for your kind speech. Okay. Hi, students. So I'll be taking what I said, that I'll be taking only one part of epidemiology. This is called mathematical epidemiology, you can say. So in this course, we'll learn how to develop mathematical model. You might be familiar with this terminology right now, because for the last 3 years, what we heard means there are so many models coming for model projection, prediction, so many things we have come to know, at least from newspaper. Even if we don't know about epidemiology, but we came to know about mathematical modeling from all the newses for last couple of years, last 2-3 years especially. So what is that? What is model actually? What is mathematical model? So let's start from this figure, this picture. I think all you are familiar with this. You can recognize this person, right? This is M.K. Gandhi, right? You can easily recognize him. But the problem is, means is the presentation of M.K. Gandhi or this one?
Sandeep, your slide has
Are you changing the slides?
Yes, you can see.
Yeah, it's not visible.
Sandeep, your slide hasn't moved. I think that's what Professor Radia was also saying. Your slide is just still on the first. Okay, no,
Yeah,
it's
now
moved.
it's
Yeah.
visible.
But I changed it in at least 30 seconds before. Okay, I should go slowly.
Okay. Yeah, yeah.
So here you can see two figures of Mahatma Gandhi, M.K. Gandhi. So right hand side figure is an abstraction of the left hand side figure, right? So we can say that this is the actual, in reality the system is very complex, but we are picking up only few lines or few strokes which represents the figure that you can recognize easily that yes, this is M.K. Gandhi, but this is not the actual figure, right? So this first one is reality, left hand side, and right hand side is the abstraction form of the same figure. So actually model is that. Model is simplified abstraction of a complex reality. Mathematical model, when we'll be going to explain, mathematically the real system or actual system is very complex. We can only capture few important points. We can pick up few important lines or strokes, so to represent the whole reality, so that you can recognize, okay, this is the person and this is the representation of that thing. So model is something, we can think that model is something like this. Okay. So what is actually we'll be learning in this class, we'll be learning epidemic modeling mainly. What is epidemic modeling? Epidemic modeling is nothing but means a way of capturing natural history of a disease transmission. We want to capture, means, like the figure, we wanted to present Mahatma Gandhi's figure in such a way that with few strokes. So this is also one way of capturing the disease transmission with some strokes, some lines, some mathematical equations in a simplified form. A way of capturing how intervention takes shape, means what we'll be doing with that model, with mathematical model, what will you do? We'll try to capture how to look after how different interventions will impact the transmission dynamics. Or sometimes what we do the cost effective analysis of that epidemiological impact, whether some intervention would be cost effective, whether actually that would be helpful to apply in the society, or that strategy would be cost effective. To do all this analysis, we need a model. Okay, we can't take the actual reality. We can't do the complex. A real system is too complex to capture. So we always have to consider some model, and then we'll want to produce the result what I want to check. But always we should remember, surveillance data or actual real data is always the best thing than the model. Model is not the substitute of the real data. We have to use real data to develop a model, and then we can conclude something making sense of the data, or we can simulate the potential control policies, control strategies from that model. So actually this epidemic modeling starts long back ago, not now. This is not a recent science. So what I'm going to talk today is just I want to share some story how this actually has been started in the mathematical modeling started in modern science, especially in the branch of epidemiology. This started long back from Ronald Ross. He was the first person who developed the mathematical model for malaria. I will speak something about Ronald Ross, about his story, and then how it has been implemented. He did it for malaria only. Then McKendrick and Carmack, they generalized the theory and to apply for other diseases, other infectious diseases. How they have done this, that I'm going to say. After that, I will what Dr. Ganesha mentioned. Just I was in ICMR headquarters during COVID period. We have developed different models, and to take some policy decision for government of India. So for COVID-19, what should we do, what we should not do. So that I'm going to share you, not the details in mathematics or what is the actual scenario, but just I want to go to tell you the story behind this policy decision. And then I will just briefly describe you different types of model, mathematical model, what kinds of models we are going to use. And finally, what we will be learning in this course, DH 301. Basically how to develop model, understanding data, and then how to calibrate model, what is that calibration, these things, and then interventions. These are the main component of the of this course actually, and few reference books for this course. So can you see the next slide? Means I am showing you some Ronald Ross figure, one photograph of Ronald Ross. Can anyone unmute and tell me?
No, sir. No, sir. We are not able to see.
I am still in the previous slide.
Yes, yes. The outline slide.
Okay, no, now I have changed. So I should wait few seconds. Someone please unmute and tell me whether I'm in the next slide or not, because I can see anyone and I'm just seeing my slides. Now?
No, sir.
Story of Ronald Ross, it has not come?
Now it's visible.
Okay. Thank you. So Ronald Ross, I think the name is familiar to everyone. He was the owner of second Nobel laureate, means in 1902. 1901, first Nobel Prize actually started in 1901. This is the second year he won Nobel. So anyway, Ronald Ross was wanted to be a writer, not a doctor or scientist. He wanted to be a writer. His aim was to be a writer. But his father pressed him to be. He wants him to be a doctor. So he appeared Indian Medical Service, that time a prestigious exam. He appeared in that exam and he qualified in 1881, though in the first time he failed. You know, in 1880 he appeared in the first time in this exam and he failed. He couldn't qualify the full courses, full Indian Medical Service. In 1881 he finally qualified and he came to India for his work, for starting his life in Madras as a doctor. So in spending in 2 years in Madras, that time in Madras, now Chennai, he shifted to Bangalore in 1883. And that is the place where his idea that working on malaria or working with mosquitoes actually developed from Bangalore. Bangalore was, from his biography actually, we can come to know that he liked Bangalore very much. It was very beautiful city, It was sunny weather, not like Britain. It was colonial Bangalore was very nice. So many gardens, etc. A quarter, and it was terrible. That was the only problem in Bangalore. At the beginning, he thought, okay, there are so many water holes, means water tanks, different cans, water bodies. So he first covered all these tanks because those are the breeding site of mosquito, and to check what is happening. And after doing that, he got a good result, means he, as expected, that mosquitoes come down, and he was so happy that yes, it is working now. And he requested the other neighbors that can you do the same thing what I am doing here in my room, then the Bangalore city would be less mosquito, there will be less mosquitoes here, and so we can do these things. But most of his neighbors ignored him. They said, oh, mosquito is also a creature of nature, so we should not disturb them. So whatever they are doing, they let them stay as it is. So they don't encourage him to do this, to killing mosquito, to reduce the mosquito numbers. So anyway, that was his first experiment on mosquitoes, which he continued his lifelong research with them, actually, with mosquitoes. Meanwhile, he went back to Britain and met Patrick Manson. He was a scientist there who worked in mosquitoes, and especially he worked in filaria mosquito, and he suggested that to Ross in a discussion that mosquitoes, I think mosquitoes carry malaria, just they carry filaria. Actually, this Patrick Manson worked on filaria in China, southern China. So that's the idea he picked up. Actually, Ronald Ross picked up this idea. Yeah, that might be possible. Let me test something, so do some experiments with them. Then he came back to Bangalore again and did his second experiment here in Bangalore. What was that? It was actually nowadays, if you do that experiment, that is not ethical at all in medical ethical. It is not ethical. What he did is that he hired, he took some mosquitoes and he put them to an infected person to bite the mosquitoes, and then that mosquitoes he kept that mosquitoes in a bottle of water, bottle with water, so that they lay eggs in the water bottle. After that, that eggs, means water with the eggs, actually is fed, offered to some of his some country people. Actually, he had some country people to drink. He expected that someone will be infected through that. Some of them will be infected. It was, I think, 4 or 5 people drink that water. But fortunately or unfortunately, no one got the infection. So what is the problem? How if malaria comes through mosquitoes, then how they propagate? Not through the eggs, he realized. So what is the what should be the reason? So the third experiment, the next experiment, he did it on birds. He didn't get some few people to do this experiment actually. So he probably these are sparrows. He did the experiment on sparrows, the one infected mosquitoes to bite the sparrows. He put some infected mosquitoes to bite the sparrows, and he noticed that yes, now the birds are also been infected by the infected mosquito. Then his belief, actually what he was believing, that somehow it is transiting from the bite of mosquito, means it is transiting from one infection to another, next one, through mosquito bites. Then he started looking at each individual mosquitoes, how the parasite is going from infected person to the blood of a bird through the mosquito. So he insects different mosquitoes and tried to his main experiments actually, where is the parasites are going, means how it is developed in the mosquito gut, and how it means reproduce within the mosquito gut, and it multiplied in numbers in the gut, and it comes to the salivary to the salivary gland of mosquito, and it bites. When it bites to another person, then the malaria transit. This work actually gave him the Nobel Prize in 1902. So this was the story of Ronald Ross, how he developed this. But where is model here? There is no modeling still now, 1902. Next slide. Let me know when it is visible.
Yes, sir, it's visible.
Okay. Now he tried to link between insects and infections. His hypothesis was removing mosquitoes was the key to control malaria. That was his hypothesis. Okay, to control malaria, we have to remove mosquitoes. He had some practical experience in South Africa, in West Africa, in Sierra Leone. That time in some work he went there, and he did one project. Okay, removing there are lots of malaria cases in that area, and removing mosquitoes, somehow he noticed that yes, malaria comes down within few months. The same experience he had during Suez Canal project. It was in Egypt. There also he noticed that when mosquito reduces, malaria reduces. That was second experience. But the problem is popular wisdom was saying something different. No one believes that means everyone's saying that if yes, mosquito can transmit the disease, that's okay, but it is impossible to get rid of each and every mosquito from our community. That means there would be always be some insects left, and potential for malaria to spread. That was common sense, means common people wisdom was saying so. So malaria would be there. We can eradicate all mosquitoes. Mosquitoes would be there. So malaria would continue. Now Ross need some stronger argument how to proceed with his idea. What is his idea? That mosquito control is the only way to control malaria. He was trying to focus how to make people understand that this is the only way to control malaria. So then what he did is he started working on starting to explain how mosquito control could help to control malaria. So can you see my slide now? Was it possible to really control malaria without removing every mosquito? Yes, right? There's some animation here, so that's why I'm worried. So he assumed that a village of 1,000 population. So suppose a village with 1,000 population. Among them, only one human is infected. Okay, that red dot in the figure, here I'm showing that infected human, and among 1,000 population. Now, mosquito numbers obviously would be higher than human population. So supposing that 48,000 mosquitoes in that village. Okay, adult mosquito, 48,000 adult mosquito in that village. Now he assumed something here. First assumption was 8,000 mosquitoes are there, so everybody is biting to human. It is not possible. So first assumption is 1 in 4 mosquitoes would manage to bite someone. That means out of 48,000 mosquitoes, only the mosquitoes can bite to human is 12,000 bites to human, right? Now, among 12,000 mosquito bite, how many will be infected? How many bites would be to that infected human? Out of 1,000 human, only 1 is infected. That was our first assumption. So out of 12,000 bites, human bites, means the mosquito can bite that person, that particular person is only 12, right? Because 1,000, you divide 12,000 by 1,000. Among all bites, only 12 bites would be such that they can pick up the parasite they can pick up the parasite from that human, particular infected person, right? But again, now when the parasite comes to the mosquito gut, it will take some time to develop. Means the parasite has to, it will actually reproduce within the mosquito gut with some sporozoites. It will develop something, and it takes around 15-20 days, 20 days around in mosquito gut. During that period, that mosquito has to survive, to bite, to be infectious, that mosquito to be infectious. At least the mosquito have to survive. The 12 mosquito has to survive to be infectious again, at least 20 days. But again, only 1 of 3 mosquitoes survive during this period. That means out of 12 mosquitoes, only 4 mosquitoes will survive to be infectious. Now, from the first assumptions, 1 in 4 mosquitoes would manage to bite someone. What does it mean? There are 48,000 mosquitoes. Now I have only 4 mosquitoes survive, infectious mosquitoes survives. Then if they started biting, means among the 1,000 population, only 1 mosquito finally bites to another human to spread the infection. Though even there were 48,000 mosquitoes in that area, an average, they would generate only 1 new human infection to that in that village, right? So could be infectious, and they can spread the disease. So what he concluded from this analysis, from this mathematical, some quantification is there. Means before that there is no quantification. Means you have to quantify things, that how many mosquitoes, how many people are there in the village, etc. So from this we can say that more mosquitoes or more infected humans means more new infection per month. If number of mosquitoes, if instead of 48,000, if it is double, then, or infected human, initially it was, we consider only 1 infected human. If it is say 2 or 3, then only more new infections per month, means infection per month will increase. We can, from that assumptions, we can easily say that. On the other hand, he also looked after, he estimated, actually Ross estimated that around 20% of infected human with malaria recovered every month. That means there is a trade-off between how many are recovering, how many are new infections in that village at a time. So if the malaria has to sustain, if the malaria has to be in the endemic in the population, number of new infection and number of recovery should be balanced out. Then only the disease will persist. But if we can create one condition where number of new infection is less than number of recovery, then automatically the disease will die out. So if the recoveries outpace the rate of new infection, the level of disease eventually would decline to 0. That means we have to, if we can create, by controlling mosquito, if we can create a situation where new infection is less than recovery, rate of recovery, then the malaria can be eradicated. So malaria cannot persist in a community unless an anopheles are so numerous that the number of new infection compensates for the number of recoveries. This is actually a statement I am reading from Prevention of Malaria, Ross's book in 1910, which is published in 1910. So that is the conclusion from it. This was the first mathematical model in this area in epidemic modeling. He also have some differential equation based expressions. I am not going to show all these things. So this was the conclusion from his modeling. So there are 2 main approaches I am saying about that time, means 100 years ago. There are 2 main approaches of disease analysis. One is a descriptive method, and the second one is mechanistic method that I am just described from malaria model, from Ross's model. What is descriptive model? Just this was actually involved starting with the real life data. See the data, how it looks like, how the epidemic goes up and down. If you see these things, then try to apply that knowledge. Okay, then now it is following this curve. So next time, next month, the number of infected people will reduce this much. This kind of descriptive method. For example, William Farr, he was a statistician, and he analyzed the London smallpox. Of course, much before us, 1830. There was a smallpox in London. So he noticed that this type of figure means when he plotted all this data, there's how many cases, number of people infected at a certain time. Then he noticed that number of infection goes up, and then it reaches to peak and then comes down. And the shape is almost equally symmetric, means mirror image of other side. So he was surprised, why this come down this way? But he couldn't explain the reason why it is coming down that way. He just noticed this thing, the same thing in 1830, again in 1840, and smallpox in England, in London. So the same thing, that smallpox going up and comes down in this pattern. Farr's method, actually, he was a statistician, actually focused the shape of the epidemic, but not why they take this shape. He can't explain that. But what Ross's, that technology, that method, what he developed, mechanistic method, we can say this, he started the online, means outline the process. He wanted to model the process, what is happening one after one. He tried to capture the process of the dynamics. And by this knowledge, he can explain the malaria transmission, the shape of that pattern, malaria pattern. And as this is a mechanistic way of using mathematical equations, he can easily check different intervention strategy. Okay, if the number of bites decreases in this much, if number of infected mosquitoes decreases up to 50%, then how the epidemic would look like. So all this kind of experiment is possible by Ross's conceptual model. So which was not possible by using descriptive model. So this is the first step of the first model on this area. That's why. After that, actually, there are two more guys who developed this area a lot, is McKendrick and Carmack. Can you see my next slide? McKendrick's slide?
Yes.
Okay. McKendrick, actually Anderson Gray McKendrick, he also qualified. Actually, he ranked top in Indian medical service that time. He was junior than Ross, but he topped in that rank, and he came to India for his service. He was in Kosoli in Himachal Pradesh. A few days. He spent few years here. So he had a discussion with Ross. He had a meeting with Ross, and he extended Ross's idea. Means not only he, along like if we can develop a model, differential equation based model mainly. He developed first, McKendrick, along with Carmack. Carmack was Carmack's background was he was actually chemist. Carmack was chemist. McKendrick was doctor, but Carmack was chemist. But at the age of 26, while he was doing some experiment in his lab, some explosion occurred, and he lost both his eyes. He was blind whole life, unfortunately. Then he started thinking, no, I can do any experiment, but I can start doing mathematics. Being blind, he has a good memory. He can memorize everything. And someone was reading, if someone reads books on mathematics and try to, he can conceptually, he can understand all these things, and he can memorize, and he can do all these things. Actually, he was a genius person in this area. So McKendrick and Carmack both tried to develop this area, Ross's idea, and at the epidemics in general. So they did this kind of modeling, mathematical model of disease transmission. So their first question was, what causes epidemic to end? Means it reaches to peak and come down. That was the first question to answer, why it is coming down. That time popular explanation for this was two things. One, either transmission ceased because There are no susceptible people left in to infect. That is one reason. There is no one susceptible. So whom to infect? That is one. And second one, the pathogen itself became less infectious, and the epidemic progressed. That was the popular explanation that time. But neither of these explanations were correct. The first one or second one, we will see why. So both are not correct completely. So they tried to explain this. They first developed that kind of model. I don't know whether you are familiar with these terms, SIR model. They divided the whole population into some compartment. Okay, how many infectious people are there in that community or in the village? So keep them in one box. They say they are infectious. The remaining persons who are not infectious are susceptible to the disease, so they can be infected from infectious persons. If the disease, if they get the infection, and they can be infected, but they are not at that place. They are infected. They are susceptible. And once they are infected people can recover after a certain time. So they will go to another box, say recovered compartment. You see that. Then from the first three terms, A is susceptible, infectious from infectious, I, and R from recovered. The first three letters actually gives us SIR. So this model is called SIR model. Later on we developed, there are many SIR type model, means not SIR model, because we can divide all these compartment into different boxes and different according to their disease status. So we develop all these kind of models. So SIR model, through this model, they gave a set of equations for this, how S is changing over time, how I is changing over time. These differential equations. We'll learn all these things later on in the class, and then in my next class I will start these things. So how these equations are developed, and if you solve the equation, then the picture looks like this. I think everybody was, you can see the diagram I am showing right now. Simulated outbreak using SIR model. Can one respond that yes? Otherwise it is impossible. Can you see the figure right now?
Yes.
I am showing one diagram, simulated outbreak. Can you see that?
Yes, sir.
Okay. So here there are three figures. You can see three curves, three lines. One in blue, one is yellow, and one is in red. That red line, which goes up and down, it looks like epidemic curve, right? That actually represents the infectious compartment. When we plot all these variables, susceptible, infectious, recovered, it looks like that. That susceptible people initially, suppose there is 10,000 people in that community or in that village. So the blue curve gradually comes down where infectious increases. When susceptible people is coming down, when number of infected people is increasing, the red curve. Then after at a certain value, the red line decreases, but blue line gradually decreases and be stabilized at a certain level after reaching certain level, not zero, but at a certain level. And when the people recovering, means as the infected people are going to come down gradually, the blue, the yellow curve, that is the recovered compartment, that is gradually increasing and be stabilized after a certain time. That means what is happening? You can see from here that it is not necessary that everyone be infected through this process, through the disease, when the disease is spreading in the community. After a certain time, means see, if everyone gets infection, then the susceptible population could be zero after a certain time, not fixed at a certain level. It could be zero. It is not happening that. After a certain time, it is coming down, and similarly, that recovered people is not reaching to a 10,000 number. There is some gap here. You see the same gap. If the total population, if there is no death, actually, if you add up all three numbers, it will give you the total number 10,000. So from coming down. It can be described from this equation, from McDonald, from Carmack and their equations, that yes, it follow the epidemic pattern, and it is not necessary that it will be reaching that susceptible population has to be infected. Every susceptible population has to be infected. And they matched with this model with some, I think, influenza. They tried to fit this model with influenza dynamics that time. So yes, it was fitting with the information, the influenza dynamics. Then there are many. This was the first step of Ross's model, and then these two models. These models, there are successive models after that. In last 100 years, there are so many models developed in many diseases, not only for malaria, but for all diseases. And you might be knowing about that COVID, what happened during that period. So many, everyone actually was modeler, and everyone was developing model and showing some projections that this could happen. Now the number of cases is this much. Tomorrow the number, within 2 weeks, the number would be this big or that thing. So there are many predictions, but all predictions, there's only few predictions were correct. We can say that that's why I always try to prefer not to predict, just project, and how we can utilize this projection for our policy decision. That is the important thing. It is not that projecting or predicting is important. Important thing is how to utilize this tool for our for the disease eradication program, or to take some strategy. That is important. I'm going to show you some examples from COVID modeling in India, from what I did from ICMR headquarters. So I will skip some slides. I think already I'm 30 or 45 minutes remains. Okay, so I can go through. So in that time it was called novel coronavirus. When it entered in China, we came to know that some coronavirus had came. COVID-19, it is renamed in the month of February, I think, January or February, and at the later stage. But initially it was known as novel coronavirus. First cases identified in Wuhan, China in December 2019. Then it was spreading rapidly, first in Europe and then USA. And we didn't know much about the disease. How transmissibility or R0, I will later on I will explain these terms. But just for the time being, you know that transmissibility is how fast it can transmit from one person to another. Transmissibility or infectiousness, these things were unknown about this disease. So how modeling can help by that period? Means without knowing anything about the disease, how can we help? How would the mathematical model can help for taking some policies? Now let's see. I will go back all these things, but through time, by means through a history of COVID history, say for 2022 onwards, 2022. So through this curve, actually I will go through this curve. I think everybody can see this curve, and everybody is familiar with this curve anyway. There are three waves, three peaks. We can see easily that 16th September there was first peak. Second peak we saw in 7th May 2021, and the third peak for the third wave came when we saw in 25th January 2022. You can see this if you Google, you can see all this data and you can search. But you should remember, these numbers, all these numbers are the reported cases of COVID-19. It is not that how many were infected. You can say from here that these many cases were infected by that time. It is only, you can say that reported, these many cases were reported by that time. On 16th September was the peak on the reported number. It was around 1 lakh. In 7th May 2021, it was around 4 lakhs. So this was the reported number. But the first cases were reported on 30th January in India. India first case reports on 30th January. This timeline is important because I will go through this time point and to show you how different models we have developed and how it is being implemented for different purposes. And our lockdown starts on 25th March. The first cases reported in Kerala on 30th January. Lockdown start on 25th March. Then unlock starts. Unlocking means some kind of removing restriction starts from 1st June. but that continues for years. Actually, it is not completely, all the restrictive measures have been removed after 2 years at least. So unlocking start on this time. And the other important time is vaccination. Vaccination start on 16 January 2021. After the first wave ends, vaccination starts. Simultaneously, as I said, that these numbers are reported number of cases. This cannot be the actual number of infected people you can find from here. But to get an idea about how many people are infected by that time, there is one methodology that is called sero survey. I don't know whether Dr. Kolani has mentioned about this term, but of course, during this course, you will be knowing about this terminology. You will be familiar with this terminology, sero survey. What we do is that this is kind of survey in the population. We collect blood from that sample from this population, and we try to find out whether those people who are infected, means antibody is there or not in their blood for COVID, so that we can have some idea. Okay, if seropositivity, if something says, some survey says that seropositivity is 25%, that means 25% were infected by that period in that community. There are 4 big sero survey conducted during this full period. One was first sero survey was in National Sero Survey, was done in May-June 2020. Second was done just before the first wave peak, actually in August to September 2020. These were conducted by ICMR. Third sero survey was done after the first wave, at the end of first wave, from December to January 2021, December 20 to January 2021. And the last and fourth sero survey was conducted on June to July 2021, after the end of second wave. There are 4 sero surveys. And you know, the first sero survey, the seroprevalence, means seropositivity, what percentage of population were infected by that time, it was around 0.7% only, mean less than 1% people were infected in India. From the second sero survey, we can say that around 8% were infected by that period. Third sero survey says that it was around 25% to 26% were infected by this strain. And fourth sero survey says it was around 70% infected in fourth sero survey. So sero survey actually gives us the how many were infected by that period. So and that number actually you can project that, okay, number of cases were infected not 4 lakhs, it could be 16 lakhs or 20 lakhs or something like that. You can have some idea about the number of infected cases by this by doing this. Now what we did is that early February, means just January 30th, the first infection occurred. Actually, we started our work before that, means before starting our infection, when it was going on outside, means in different countries. And in India, we started the thermal screening. Initially, now we are familiar with the thermal screening, but at the early days, in early January or February in 2020, we were looking that with thermal gun, everyone was getting tested whether they have fever or not. So, so we saw those things those days, and whether that is useful or not, whether by thermal screening we can prevent the disease, we can to enter the disease in India, that we are trying to understand. So what we did, we developed one model, very simple model, without knowing anything, means we don't know about the transmissibility, just we came to know about transmissibility slightly from other countries. So this could be, transmissibility could be this much for this disease, like other coronavirus diseases, other SARS virus, from the other knowledges. So it could vary from this to this. So with that, we tested that, okay, if we and thermal screening actually gives only the symptomatic cases. They can identify by that okay, the person has fever or not. We can identify that and we can isolate them. So if we can, at the airport or other ports or other entry port, if we do this, if we continue that kind of screening, that even 100% screening, if we can isolate them immediately after getting that this is infected or symptomatic cases, then only this actually figure represents that number of time to reach prevalence cases, 1,000 cases in India. So you see that blue curve here at the first panel, Here and at the x-axis it represents the what percentage we are covering, what percentage of people are isolating by symptomatic screening. If we isolate from 20% to 100%, x-axis represents from 0% to 100%. If we can isolate these many people, then the time to reach 100 population, 100 new cases will be hardly any changes. Means initially it was say 45 days. So at the end it would be 47 days or 48 days to reach 1000 cases. That means there is no impact of thermal screening if we screen only symptomatic cases. But if we can screen asymptomatic cases also as well, those are asymptomatic, if we can somehow isolate them, then only we'll get some time to avoid number of cases to reach 1000 cases. So this is the right hand panel, the red figure actually shows that how many days it will take. Nearly 100 days it will take if we can cover 95% asymptomatic cases. You can isolate 95% asymptomatic cases as well. That means we said from this actually experiment, we said that it is not possible to stop spreading the disease in India by thermal screening. We can only delay the process if we can, that is also we have to isolate the asymptomatic people. That actually in reality we all know what happened. We couldn't stop the process and it spreads over India. And the next step what we did, that this is not the only thing, from the same model, that was very simple model. From the same model, we have shown that what could be the, means we did not know about the transmissibility. We just developed scenarios. Okay, if transmissibility is less, if transmissibility is very high, if that asymptomatic cases were also infectious us, we didn't know that time whether they are infectious or not, asymptomatic cases. If they are infectious, if 50% infectious than symptomatic cases, then how the disease will propagate and how can we reduce the peak of the epidemic. Peak prevalence, how it will be reducing. If you can identify 50% symptomatic cases in 3 days, then how much we can reduce the disease. That we have projected to this model. That actually all research article that time on COVID was highlighted by different newspapers, like was this, and suggest that need to add and new test to quarantine plan for lockdown, etc., etc. There are many news comes on this work. Then okay, that's fine. Now comes time passes. After February, we actually published during this period, means in February it published. After that time passes, first sero survey has started, and we know that first survey we will be getting some information on first sero survey result. So let's try to utilize that data. Whenever new data is coming, we try to utilize those data and to get some new information, what we can project from model, whether that information is useful or not. So with the seroprevalence data, what we first did is that we calibrated the model with the seroprevalence. Can you see my screen now? I'm showing one curve with the actual daily symptomatic cases. Can you see this? Can you please tell anyone?
We can't see the curve.
You can see, okay. So you remember that at the end of first at the peak actually, the seroprevalence was 8%. That means 8% of the Indian population were infected by that time. If that is true, then the curve should look like this at the blue line, not that black one. Black number, that black bar actually, these are actually the reported cases by that period, and blue line is the actually projected number through sero survey, utilizing sero survey. So number of cases could be, though prevalence cases, though reported cases is this much, but actual number could be 4 times higher or 5 times higher than this much. This gives, this was the model projection at that time. Additionally, as the lockdown was continuing, how can we utilize this sero survey information to remove lockdown? That was another strategy. So this plot, left-hand side plot, actually shows you the persons needing hospitalization with respect to days. So this is not epidemic curve, this is needing hospitalization. Because in India, average hospital bed available is around 2.5 per thousand population. Now, if the number of infected cases is too high, that hospital bed is occupied fully. So what to do? So we have to take some strategy so that hospital bed, that people get some hospital beds when if someone is infected. That should be our strategy. So if you don't do anything, if we don't do any lockdown or any methods, then we can get this blue curve, blue line. You see here. But if we can reduce transmission by lockdown or any other method, say the transmission got reduced by 50%, then the curve could look like that red line. Okay, with lockdown strategy. But our hospital bed, available hospital bed is per 1,000 population, is in the dotted line. It is showing that there is a level of hospital bed. So we could, if people are infected less than that dotted line, then everybody will get the hospital bed. Otherwise, if it exceeds, then people will not getting bed in hospital as well. That happened actually during second wave, you know. So this was the situation. So our strategy here from the another model, we showed that if we can test, what could be the testing strategy? We decided that if we can test and quarantine these many people within these many days, then the hospital bed capacity will require, so that the hospital bed capacity will require below that line. That was our intention to check, means how to do that, how to reach that. So if 70% got reduced, 70% transmission got reduced by lockdown method, then we will have a peak, lesser peak. Then that means we can follow that blue, that yellow curve. The hospital bed, what is available and what is required would be fine, means balanced with that period. But there is when lockdown would remove, this red band actually shows the lockdown period. If lockdown will remove, there is a chance of another epidemic. Second peak, you can see the second peak. And this is done much before the second peak started, means actually when we did this work, when the first peak was appeared, this work. So we are doing these experiments. Okay, if we lockdown, remove the lockdown, what could happen for the second peak could appear? And what could be the strategy? How many test cases has to be tested to avoid that situation? The bottom curve actually shows that to avoid this, to reach the peak of the yellow line, to the bottom of the dotted line. What could be the strategy that we proposed through this analysis? So again, it says that we had done some cost effective analysis also to test what percentage of means 2% of our economy, how many economic losses would be by this strategy, etc. We did this analysis for the trial. Anyway, second wave appeared. We saw the second wave, and anyway, we couldn't avoid the second wave. But we did this analysis during this period after the peak, during the peak of first wave. Now the vaccinations came in India, means vaccine on 16 January in 2021. But we came to know about the different strategy, different vaccination testing that has been started much before, when it actually in reality in 16 January started, but much before that we had implemented, means testing strategy was done for Covishield or Covishield. All these things are conducting. So we didn't know that what could be the vaccination efficacy. We need to know that. So, and also with that, if vaccine comes, then how to provide the vaccines to among the population, means to 1.4 billion population in India is not a huge population. So how to distribute that? It is not means we should have some strategy. It is not that in market it will be available, everybody will take the vaccine. It is not possible. So what could be the strategy for vaccination? We started working on that. So this is the period, actually red band here I am showing. This is actually period when we did this work, this analysis before starting the vaccination. So we divided the whole population into some priority groups. So whom to prioritize first? So that was our first questions. If vaccine comes, whom to prioritize first? We divide the population into three broad categories. One, those are key workers, means those are doctors, nurse, or those are frontline worker, we can say, even military, police, those peoples, around 27 million people in India. They should be priorities first without due to ethical reason, because they are doing their direct contact with the infected patients. So they should vaccinate first. There is no doubt on that. And then the next step is whether we should vaccinate older age people first or the people who are with comorbid. Individuals with 24 to 60 years old who are comorbid, means having diabetics and other diseases, who has a chance of dying. So whether we should prioritize them, whether we should vaccinate them first, then the older age group, or the other way around. So through this analysis, then another model we developed, and with these three broad categories, and we said that yes, we can, of course, we have to give the vaccination to key workers first, and the next step would be if depending on the transmission setting, if it is in high transmission, relatively high transmission setting, then older age groups should be prioritized than the comorbid group or middle age group. But if in weakest transmission setting, when the transmission is slightly lesser, say in village area, in different village areas, their comorbid, should be priorities first than the older age group. All these are published articles. You can see all the references. You can see later on. We will share these slides. You can see these references. You will get all this in details. So then that was whom to vaccinate first. That was the question. Next, where to vaccinate first? India is a big country. Where we should start vaccinating, whether in the village area or rural area or where? So that was another question we tried to address through this. And how can we do that? So we have noticed by that time first wave and second wave already started, means we can see the first wave and second wave. And in between, this is the plot, and actually plot A is showing that test positivity rate. A red curve shows the test positivity rate, and the blue is actually the daily number of cases, reported number of cases. And they are so linked, you can see they are linked. And we notice that at a test positivity rate equal to 0.5, when test positivity rate is only 0.5%, suddenly it started increasing. If we look after this scenario for all the areas, means all the district level, at district level or state level, then we can fix a strategy. What would be the most effective strategy to which areas should be prioritized first? We can do that. I'm not going in details about the modeling, just I'm mentioning this thing, how to do it. Then the next question we address before third wave, plausibility of third wave. It was a big question that time. It was concerned about the third wave. Even you know, all you might be aware about this. Means if you follow the newspapers, always they were looking for some news, something panic. They would always try to spread panic. Okay, what is happening? What will happen? Many people are saying that now new variant is coming, and so it would be very big. Children will be affected more, etc., etc. There are so many news coming that time. So we started looking after thinking scientifically, or how to proceed with that. Means for whether there will be a third wave and how big that could be. So we're trying to do this experiment during this period, during the second wave peak, or when it is coming down. During that period, we are doing this experiment for developing third wave. We can't say anything about that when it will be coming, when the third wave will start rising. But we can postulate, okay, if that third wave starts here, then how the curve would look like. So we were thinking what could be the reason for third wave. Now we know after second wave peak, already seropositivity is around 70%. 70% people already got the infection. Antibody was there. So what could be the possible reason of having a third wave, big third wave? So these are the four postulates, four main reasons we assume that this could be the reason if third wave comes. One is if we remove restrictive measure, what was till then. If we remove restrictive measures suddenly, then there is a chance of the remaining susceptible people are there, so they could be infected. There is a chance of third wave. If the immunity wanes, because the person who got the infection 2 years back in 2020, say January, February, they can lose their immunity. We didn't know how many days the immunity stays continues. So they can wane the immunity. So if immunity wanes, then there is a chance of reinfection of those people again, starting again infection. So there is a chance of third wave. This is the second reason. And third and fourth reason, as we assume that there might be new variant of the virus. Virus is evolving. So if new variant comes, if something comes, new variant comes, for which the transmissibility is much higher than the second wave virus variant, that is delta wave, and that was called delta wave. Second wave mainly for delta wave. So if delta virus, I mean, so for that, if some variant arises for which the transmissibility is much higher, then there is a chance of big third wave. And fourth reason could be the same new variant, but which maybe the transmissibility may be the same, but it can escape the immunity what is developed during the first wave, first wave or second wave, and for that variant, that immunity can escape this new variant. Then there is a chance of third wave. So we tested all these scenarios, and combination of these scenarios, what could be the possible wave look like, third wave look like. Then we have seen this is one of the scenarios. We have developed many scenarios, that this is one of the scenarios that okay, third wave could look like this, and with vaccination strategy, this blue line, this is the third wave with some transmissibility and immune escape capacity of the virus. But the red actually shows with vaccination the third wave could look like this. And here I could mention that looking at this figure, means when we published this paper, different newspaper picked up this figure and said, okay, this ICMR study suggests that the third wave would start from say October, this date. This is not true. We never said that. We always say that if the new variant comes by this period, then the third wave, how third wave look like? Third wave could look like. That was our postulate. But that's why you can't really believe all these newspaper articles always. So you have to go through this, what is happening actually in reality. So what we suggested after this analysis, what we suggested was something like this. That was our conclusion. Third wave was unlikely to be as severe as second wave. It is not that it could not be that big as second wave and that devastating as the third wave, because these kind of scenarios we can develop, we have seen. And in reality that happens. Even the peak could be higher. If transmissibility is higher, then the peak could be higher, but the severity was lesser. So deaths were much lesser in the third wave actually in reality. So that was national level figure. Now the question comes, is that true for all states? India is a big country. There are so many states and districts. The nature is so variant. Means in Delhi, the situation in Delhi, Maharashtra is not same in West Bengal or in Bihar or in Madhya Pradesh. So situation is different from different countries and different parts of the countries. Even district level, the situation could be different. So actually now the question comes that how can you utilize? Can you develop one tool so that would be useful for district level, so that district level health authority can use that tool to project what should be the preparedness, how to prepare for the next wave with their data. So we tried to do that. Actually, we developed one tool. We say it's Chromic tool, Chromic model or Chromic tool. It is actually a tool which is developed by ICMR, and this collaborative. Chromic means collaborative health research on modeling with Imperial College London and ICMR. This is a joint effort, so that's why the name is so. So so we developed this. The background model is our model, and one Dure Technology, one Indian company that is Mumbai based actually. Where are you right now? So that company helped us to develop this web tool with the backbone of our model. So we give our model structure. The left-hand panel actually shows that input data, input parameters, what you have to give. Means any district level people can put their input. When was the date of first wave peak? What was the seroprevalence by that time? From their information, if they put, and some other information is required. All are not. You can see all these things if you have to scroll down there. And I'm just taking the screenshot. So if all this information, if you put and simulate, it will show in the middle figure, it will show how the third wave would look like for that state or for that district. And in the right hand panel, it will show the healthcare demand, how many hospital beds should be ready by that time at the peak positions, how many oxygen is required. Means they have to be prepared for these things, right? So what should be the strategy? This is helpful tool for different states. So this is the one scenario, projected scenario, how the third wave could look like for some district, actually, for India, I think. With some scenarios, we can develop different scenarios, symptomatic, asymptomatic. All these cases are shown here. That here red curve is so big because asymptomatic cases is showing, symptomatic plus asymptomatic, and blue one is the symptomatic case only. So, and the right hand, it will give you the numbers. Now for respective states or districts, this has been circulated through Government of India from the Health Research, Department of Health Research. We went through our Health Secretary. They have circulated this web tool to all states to join, and we took some classes to training classes actually to how to utilize this tool so that they can be prepared for the third wave. It has been utilized for, I can say, for all states, but at least 10 or 15 states, big states, they utilize these tools. They at least get training from us and try to utilize this. How to be the preparedness for the third wave. So there are lots of works I already described for modeling. All these are done through mathematical models, right? So what we learned from these experience, actually, for 3 years experience, for if we used it properly, that properly used it properly is important thing, because we can always postulate, we can model can do anything. If you if you put give some input value, it will project something. And if you conclude from that projection itself, you have to be very sure that you are doing the same things, the right thing. You have to go back to, you have to consult with certain person, like some epidemiologists, some physicians, all the relevant fields. It is fully interdisciplinary area. One mathematician or a physicist or one computer biologist can do these things by alone. Always collaboration is important in this subject. Always you have to talk with them. But understanding is required to everyone. That epidemiologist has to understand that what is the background of mathematical models. They can run the model, they can develop the model, but they have to understand the scenarios. Then we can explain them that this is happening here. So if this is correct, can we apply these things? So we have to use it properly. That is the first thing. Second is model outcomes can depend on the assumptions. Means if you change the assumptions, the projection would be different. And it is always important, if model projects something, then we have to go back. What is the reason behind it? Why model is showing so? So you have to understand the reason. Okay, this might be the reason. Why? What is the particular point? Why model is showing that big peak or smaller peak? You have to understand that thing. That question is important for epidemic modeling. So that means we have to incorporate, bring together our best understanding of epidemic and projecting their implications under given future scenarios. We can think about using a model. And we can, I always, previously also, whenever I present something on this, I always say that we can project but not predict. We never predict anything. Prediction is not our work, but we can project. We can project different scenarios. We project through model. So these are our experience from modeling. And now, what are different kinds of, there are different types of modeling, depending on the scale and temporal and spatial dynamics. If you look after, then for malaria, say, if we have to consider, if I think about a mosquito or larva development, mosquito larva, how it develops, its scale can vary from this presentation. Actually, I like this presentation. I took it from some, I think from Nature, in some journal it published before. It's not my work. So there they presented this. I like it. Spatiotemporal scales, how the disease dynamics can look like. It could be from centimeter scale to the Earth size in the spatial scale. In the temporal scale, it could be from hour to centuries. Okay. If we think about larval development, it could be within few meter range and within few days. If we think about mosquito, adult mosquito, it could travel few 100 meters, say, in the range of 100-meter scale, and it could survive up to months. So if we think about weather, how weather is affecting mosquitoes, weather is influencing different diseases. So that could vary from kilometer to say 1,000 kilometers. It changes over time, over space, and it also changes over month. If we think about El Nino or ENSO, that southern oscillations, that wide range is, of course, increases. And global warming, if you consider how global warming is affecting our different diseases, then you have to think out to the scale at the centuries and in the time scale in century, and of course in the globally we have to think about. So these different scales will be working on. Say for this kind of model for COVID, say for example in COVID, for a particular state it is in few kilometers to 1,000 kilometers, say. If we consider national level, of course 1,000 kilometers, but if you consider on state, that is also kilometers. But the duration we will not take means in years. When we develop model, we'll try to do it for days. How every day it was changing. The pattern changes in day wise. So we have to look after in days. But if we think about, say, TB, tuberculosis is a long-lasting disease. For a long time, it is continuing still now. So we have to consider about years. So these many years, and last 15 years, how TB is propagating, how the pattern looks like over time. So in different scales and space, we have to think about that. We can present that disease modeling or disease dynamics. Mainly, there are two types of modeling, disease modeling. One, I can say that mechanistic way of modeling. The example I gave still now, all these are mechanistic way of modeling. We need to know the process, and we'll do this. We'll implement it. We'll simulate it, and we'll try to find out some information from here. That is the mechanistic way of modeling. Another approach is the database modeling. That is statistical modeling, we can say, mathematical and statistical modeling. What is that? There we need to collect data. As much as you have data, you can get more information. Actually, we can postulate something from there. So you have lots of data. Some we have to find out the correlation between different data, whether they are correlated or not. Then how can project from regression modeling or different types of modeling there itself has for statistical modeling. Those are statistical database modeling. But in this course, we will focus only the mechanistic model, not the statistical modeling. So, but ultimately both models should line up with the real observations. Means both should give the same results. That is the ultimate aim. This one is an example for database statistical modeling, how it looks like. Say there are two panels. First panel is shows for Chennai and second one is for Mangalore. Chennai means here, these are the slide positivity rate. Means you can think about that malaria cases. That is directly linked to malaria cases. How malaria cases were changing over time from 2002 to 2004. In first panel, this bar plot actually represents in the top bar plot. In the right-hand panel, you can see the beautiful pattern. There is in Mangalore, how malaria cases increases and decreases every year. You can see this pattern. Now, how these malaria cases are linked with the different variables. We know malaria, actually mosquito, the number of mosquitoes or mosquito density increases with when rainfall, after rainfall, or humidity. That particularly depends on humidity, rainfall, temperature, etc. in different weather conditions. So at the bottom panel, these are shows the respective rainfall, humidity, and rainfall, humidity, and temperature actually. So how they are linked, whether they are correlated with this data or not, that you need to test first whether they are correlated. If they correlated, then we can find an equation between mosquito cases, means number of cases, and all these variables. Now, if we give ultimately, once you have that equations, you can put all these variables. This temperature is this month, weather condition is this month, temperature is this month, humidity is this month, then number of malaria cases. What is the expected number of malaria cases? You can do this way. This is actually blind about the process. Means they don't. When we do these things, we don't know about the process, how the transmission is going, how the transmission is propagating. We don't know about. We don't need know about these things. But we need to know only the data. So these are the data, how they are related and how they can project. Many people do this kind of modeling. Even during COVID period, many people were trying to fit with the data, with the reported data, and the number of cases would be this much. So the next we are expecting this number of cases after this. But that will not give you the reality. No. So will be mechanistic way of approach that we'll be doing in this class. We'll learn this class. Different types of theoretical approach we have. I'm giving some examples of something like this. Standard differential equation based SIR model. I mentioned about SIR model. Actually, in this course, we'll be learning these things. The first one, standard differential equation based SIR model. This has been used in multiple purposes. And there are other types of models. These are differential equation based models. There are discrete models. You can write discrete equation, and you can develop the model in that way. How population grows, how parasite develops within that. We can do this thing, discrete modeling. There is another modeling called agent-based modeling. You have to consider each and individual model as an agent, a person as an agent, and then give characteristic of each model. Then computer simulation will give you the result, how the disease will spread. There is another type of modeling, but this is fully data intensive. You need to have very much, means lots of data for this input as input, how this agent-based modeling. That's why I like mechanistic modeling better than agent-based modeling, because with limited data, we can conclude something, and we can understand each and every step, what is happening, why it is happening. That is important. There are other types of modeling called network modeling, where lattice-based modeling. These are different types of modeling. But anyway, we'll be focusing on the differential equation-based model in the courses. Okay. So this is the course content, what we'll be learning during this course. What we are expecting to learn is the first we will learn before model development, actually data. Understanding a data is important. What data is, what is the meaning of something, rate, different rate parameter, proportion, and we need to know the languages of medical persons. Means say from the language of epidemiologist and language of mathematician is different. I can give one example. If we can say, if our longevity is say around average longevity of Indian population is 70 years, then we can say that death rate of natural death rate of Indian population is 1/70, right? 1/70 per year. Every year we are dying by that rate. But if you go to some epidemiologist, or if we go to some doctor or health worker, they will say for some disease, suppose they say that by this infection, the 10% population are dying by this infection, by symptomatic infections. So 10% and that 1/70, that is completely different things. You need to convert that 10% to a rate to put in the model. So we need to understand what is the meaning of 10% and what is the meaning of 1/70 per year. So we have to understand these things first. What are the difference between the competing hazard, this terminology you need to know to pursue with this course. Then we learn model development, how to develop a model, simple model, and then gradually we'll go to the complex model. Force of infection, reproduction number. There are several terms. Reproduction number might be familiar with this name, at least from the newspaper. So what is that? We'll learn these things systematically. Then we'll learn, after model development, the next important step is the model calibration. That is very important step. How to calibrate model with the real data set. This some optimization technique we need to learn. These things we'll learn here. And the final step is the modeling intervention. How we look after that these interventions, the vaccination will give me this impact, or this many treatment will give me this impact. So how to do that? How the interventions shape the pattern, that we learn at the end. So these are the course content for this lecture, means what I'll be teaching you for few lectures. And there are some books, I can refer these books, and there are many other books. You can follow any books. It is not, there is no that what is available at IIT. There might be some books available in the library there also. So mathematical models in biology, that is good, very good book, biology. Or even there is another book, even whatever is shown here. Other than that, there is one book is called Infectious Disease Modeling by Anderson and May. This is Oxford University Press. There is also a very good book in this area to learn, to start learning this book. Okay, that's all for today's lecture. And let me know, I can't see anyone of you. That is, it is unfortunate that I couldn't go there due to other workload. So, but yes, you can interact me through mail. You can just let me know. And just now, if you have some time, you can ask me some question if you have. Only 5-10 minutes remains. So you can ask if you have any questions. Thank you for your patience. Long classes, 2-3 hours classes.
Hello.
Hello.
Hi, sir. Can you hear me?
Yes, I can hear you.
So I wanted to ask, what's the evaluation pattern for your part of the course?
So that would be actually what we have to decide. It is not decided yet what percentage will go to that Kolani ma'am's part and my part, but it would be a little, maybe 20% would be my part, say 80% is from Kolani ma'am's part. That way we
So
can
Dr.
divide.
Kalyani just now said that your part will be 50%.
But classes wise, I can do that, but class wise it would be difficult. Means 50%, I will not be. I don't know whether I will be able to take that many classes.
And yeah, like at the same time, what will be the pattern of evaluation? Like, will it be MCQs, mid-sem, end-sem? What will be the pattern?
Okay, that is a good question, and we have not decided yet. First of all, we have to have means that's why I need to know how many students are there from different backgrounds. Finally, I need to know. Maybe after this talk, I will have some clear pictures. Accordingly, I will divide. I will develop the syllabus actually for these courses. So if students knows about the programming, means some languages, either Python or MATLAB or any languages, if they can develop some model, if with some assignment, I will give some assignment, and if you are able to develop some writing some code and some results, I will give some. For example, I will give some problem to you, and if you can answer that with simulating that problem, you will come back to me, and we can analyze those things. If that is possible, with the guidance of few students from assistants from IIT there, then it is possible to take some even project work also.
Yes, sir. Actually, it'd be better if we get evaluated on assignments and projects rather than conducting midterms or exams, I feel.
Yes, that's what I'm thinking. But
And
that
so at the same time,
that all depends on the number of students. How many students are there? Because for me alone, it is hardly possible to handle 50 students to see all this evolution process. Very difficult. So let's discuss with Kalani and Dr. Ganesha. We'll discuss later.
sir,
Then I will come
sure.
to all you.
So at the
I think
same time, can we change the mode of classes? Either you can come offline, or like you can conduct the online classes, but not be in person sitting in a classroom and attending your online class, because it's really not feasible. We're not able to hear you clearly during the whole lecture. If you can
okay.
come offline, or either we attend your online class, that would be better,
That would
because
be
we're
better.
not able to hear you.
Means I would prefer, of course, online. But if you can join also online, then I can see you at least. I can see your face who are who are attending these classes, and what is your
Online
questions. And
lectures,
if I could came to know here
Teams
is
and
this
meetings.
communication gaps. Means I don't understand how many you can get my points. What I'm trying to explaining is very difficult. And I will try. Of course, I will try to at least attend one or two classes over there. But rest of the
So
class I
actually,
will take
it's
online.
just that we're not able to logistically, like logistics are not very clear that we can hear you in the class while you're teaching
Oh,
in-person online
sorry, I'm very
classes.
sorry.
So,
Mhm.
so
I'm
like if we can join the Teams meeting itself, we'll be able to hear you clearly.
Then that would be fine. I am perfectly fine with that.
Yeah, that'll be better.
That would be fine for me. That would be fine, perfectly fine. But of course, I will try to attend at least one class to meet all of you. I would like to
Yeah,
interact
sure,
with
sir.
you personally. Okay,
Sure, sir.
then
No
we can
issues.
discuss a lot. This is not a way, means I don't like online classes. That is not true. But it is far, and with my workload, it is
Same
very
here, sir.
difficult to be there always. Mostly I have to take online classes, but one or two classes I will be going there, and I will take some interaction. Let's say.
Yeah, sure, sir. Thank you so much. Thank you so much.
Okay. Any questions anyone has? Means if you can come forward and you can ask any students if you have any other questions related to this topic. If no, then we'll meet in next class, maybe in the online. We can see each other.
Thank you, sir.
Okay. Thank you. Thank you very much. So I'm leaving this meeting right now.